Suicide is the leading cause of death amongst male residents, second leading cause of death amongst female residents, and it doesn't simply go away after residency is over, but remains a huge problem for physicians in practice. Sid Zisook, a psychiatrist, professor of psychiatry at UC San Diego, and also the director of the Healer Education Assessment and Referral Program, otherwise known as HERE.
Welcome to episode 54 of the MDedge Psychcast. I'm the voice of MDedge, Nick Andrews. In this Masterclass edition, Dr. Zisook examines a topic of vast importance among healthcare professionals, physician suicide. And later, Dr. Renee Kohansky talks about what can be spoken into existence. And don't forget, you can contact the show. In fact, we'd love to hear from you regarding your ideas, suggestions, feedback, or questions for Dr. Norris, or even a shout out for a colleague or a mentor. You may have your email read during a future edition of the program. You can email the show at podcasts@mdedge.com, or you can follow us on Twitter at MDedge Psych. And speaking of Twitter, we're excited to tell you about a live Twitter chat sponsored by MDedge Psychiatry on dealing with the aftermath of losing a patient to suicide. The chat is set for Wednesday, April 24th from 6 to 7 p.m. Eastern Time, and will be hosted by Dr. Dinah Miller and Dr. Eric Plakin. Mark your calendars, April 24th between 6 and 7 p.m. Eastern Time, and join us at #MDedgeChats. This episode is complete with show notes, including more details and data mentioned in Dr. Zisook's lecture, such as suicide among residents and physician burnout. Here now, Dr. Sidney Zisook.
I'm going to be talking about physician suicide, a topic that unfortunately is sometimes considered an occupational risk, because it is so prevalent amongst physicians, and for that matter, other healthcare workers as well, who have high rates of suicide, especially compared to other people of equal education and gender matched. The problem of physician suicide is not new. It's been here for a long time, but we're finally beginning to talk about it. And I think that's the first step towards being able to do something about it. In the past, physician distress, physician depression, physician suicide have been shrouded in clouds of silence. As such, there just have been no attempts at prevention or really few attempts to deal with the well-being of physicians in general. Physician suicide, like suicide in the general population, suicide in the general population is, I believe, the only one of the top 10 causes of death in the United States that's on the upswing. The others, treatments are being developed, and rates of death by other causes of death are going down. Suicide's going up. There's been about a 30% increase in suicide rates in the United States over the past decade, and physicians are not immune. We don't know if rates are going up amongst physicians because there's not really a terrific database on physician suicide, but they don't appear to be going down at all, and more likely than not, they're keeping pace with the general population. Suicide is the leading cause of death amongst male residents, second leading cause of death amongst female residents, and it doesn't simply go away after residency is over, but remains a huge problem for physicians in practice. In fact, I, at one point in my life, lost a personal physician to suicide, and I know I'm not alone in that. The numbers that are given, the best estimates of physician suicide, are that there are about 400 or so suicides in a year. If you think about it, that's more than one a day. Also, that's the equivalent of 3 or 4 graduating medical school classes. That's a huge, tragic, and needless loss. If you think about all of the people that are affected by physician suicide, particularly the thousands of patients each year who are losing their physician, the magnitude of the loss is tremendous. So what can we do about it, and why is there that kind of rate? And the answer about the why is we simply don't know. We can take our best guesses. And one of the best guesses would include just looking at the kinds of people who go into medicine. They tend to be a very conscientious group of people who go into medicine because they care about patient care and want to deliver really excellent patient care. People going into medical school and doing well enough in terms of grades in high school and college are people who are prone to put off immediate gratification in search of being able to meet the highest standards possible and get into medical schools in the first place. And then in medical school, it's people who are still willing to give up immediate gratification, who want to get into the best residencies possible. So the competition is immense, and the kind of person who succeeds in that competition tends to be someone who has kind of compulsive traits. They're willing to focus on one thing at a time, a sense of being able to master any obstacles, which can lead to a sense of perfectionism, which can lead to a sense of inability to adapt to and cope with and accept times when we're imperfect. In medicine, we are imperfect. We deal with really difficult malignant diseases. Death is a part of life, and in medicine, we meet people who die. We treat people who die. As a psychiatrist, I know we treat people who ultimately die by their own hands, die by suicide. And as such, we are facing what we may consider a personal failure on a fairly regular basis. And if we think of it as a personal failure, it becomes very hard to accept. Rather than thinking of illness, chronic illness, treatment-resistant disorders, and ultimately death of patients as part of life. And if we do tend to feel like there's something we could or should have done differently, that we could have prevented it, that it's an imperfection in us, then guilt and blame can become a part of our reaction. And guilt and blame in a vulnerable person can if not in their own, lead to suicide, but can be part and parcel of a picture. Suicide itself is not caused by any one simple factor. We do know that there are certain vulnerabilities to suicide. There are biological vulnerabilities like the serotonin system being more prone to have issues related to it in people who end up being suicidal. If you're unlucky enough to be born with a short allele of the serotonin transporter gene, you may be more prone to depression or suicide, especially if you've also had early childhood abuse or mistreatment, and especially if in that context you also face stress in adulthood. And being a physician is a stressful occupation. Again, in part because of the illnesses we treat, but in part because of changes that are occurring in the healthcare system. There's been lots and lots of discussions about burnout, and underlying burnout are demands and expectations for physicians that exceed the resources to meet those demands. And in a chronic situation, that can be exceedingly stressful. It can lead to burnout. Burnout can lead to depression. Depression is a very common underlying condition in people who ultimately suicide. Probably the two major risk factors for suicide are a past history of a suicide attempt and depression, and especially depression which is untreated or inadequately treated. And again, physicians are vulnerable here because physicians, just like other people, are influenced a lot by stigma about mental illness and mental illness treatment, and in fact may even be more stigmatized than the general population for fear of getting treatment for a mental illness interfering with their ability to be promoted or even to be licensed. In reality, in most states now, on licensing applications, the question is not whether you've been treated for an illness, but whether you're impaired by a current mental illness. But still, physicians are very frightened. And in some states, the question is, have you ever had a mental illness? Have you ever been treated? And that in and of itself will discourage physicians from getting treatment. So you've got the other factors of vulnerability, like untreated depression, like biological vulnerabilities, the stresses and strains of everyday life. And added to that are the stresses and strains that are unique to being a physician. And as I mentioned, part of that is just dealing with difficult patients. Part of that is the healthcare system. And one of the things that's occurring in the healthcare system now is increased documentation demands and the electronic medical record. And when you ask physicians, what are the underlying causes of burnout in your own practice, electronic medical records are always very high on the list. They're cumbersome, they're time-consuming, they ask for documentation of all sorts of information which is not readily apparently related to quality of care or patient's well-being, but they take time, and it's easy to get bogged down on them. One fairly recent large survey found that physicians are actually spending more time on electronic medical records during the day than they are face-to-face with patients, and they're even spending time at home during what should be family time and relaxation time, completing those same medical records. In addition, anyone who's gone to a physician recently probably has had the experience of their physician, instead of looking into their eyes when they're working with them, looking into their computer and trying to get as much of the electronic records out of the way as they can. But that interferes with the ability to form relationships with patients, which, after all, is the reason most of us go into medicine in the first place, to develop and foster those kinds of ongoing relationships. So the workload is not decreasing. Documentation is increasing. The need to keep up with continuing education in order to maintain licensing is increasing, if anything, and yet no one's giving anyone the resources or the time to add these additional burdens to our practice. So we're squeezed. We're squeezed by having more requirements. More of those requirements being non-patient requirements, documentation and being involved in technology, and no one gives us time to do it. We're also, in this modern era, we're tied to electronic devices. It used to be when you took a vacation, you were on vacation. Now you take a vacation, your cell phone's with you, you're available to anyone who cares to call you, patients if they have your cell phone number, colleagues at work, staff at work. And not only that, most of us tend to try to keep up with email every day we're on vacation. And whereas maybe a decade ago, that didn't take too long, currently, myself, just to keep up with email, I'm probably talking about a couple hours a day. And so, again, we're just being squeezed in so many directions. So because of all that, depression goes untreated, suicide rates remain high, and the good news, though, is people are finally paying attention. And organizations are paying attention. Organizations are putting up new guidelines. There's new rules and regulations for residency programs that residency training directors have to not only prioritize their residents' well-being and mental health, but also have to attend to the faculty's well-being and mental health. That's a responsibility of training directors, is to make sure the faculty also is taking care of themselves, because a burnt-out faculty member dramatically affects a resident as well. So this is a lifelong process. And On the one hand, new rules and regulations are occurring for that, but on the other hand, the goal is a virtuous one, and that is that physicians take care of themselves and each other and provide support for themselves and each other. We hope that with that kind of support, a sense of wellness and well-being and quality of life and pride in being a physician can be restored. And it doesn't take too much of a stretch to think that ultimately that would increase the likelihood of physicians taking care of themselves, increase the likelihood of them getting treated for depression when it's there, or anxiety disorders, or substance use disorders, etc., all of which we think would dramatically reduce the rates of suicide and increasing the probability of physicians being engaged and enthused and invigorated by the work they do.
And that concludes the lecture portion of the show. Don't forget, you can learn more on physician suicide by checking out the show notes. We'd like to thank Dr. Zisook for joining us this week. It's time now for Dr. Renee Kohansky.
Thanks for the introduction, as always, Nick. So words are to psychiatrists as scalpels are to surgeons. No, that's not quite right. Let's try words are to psychiatrists as stethoscopes are to cardiologists. Again, that doesn't quite capture it. Words are our instruments of diagnosis, healing, and change. They are also sources of creation, not just in psychiatry, but in life. I've discussed this in other programs, and it's such a powerful topic. Undoubtedly, I will discuss it in future programs. I had a patient the other day whose long-standing issues source from safety. She doesn't feel safe in life. This is based in a history from long ago and truly, actually, long ago mastered. She just doesn't know it. Despite many models of therapy in which she has engaged over the decades, she has never been able to achieve that core base feeling of safety. So we could continue to approach her dilemma from many different models, analytic, Freudian, cognitive behavioral, but I decided to try something a little bit different, beginning with psychoeducation. Our brain constantly talks to us, feeding us opinions about all sorts of things 24/7 nonstop. It has something to say about everything. It's judging this program you are all listening to right now. It's judging you. It's always judging you. It has something to say about you all the time. Sometimes it's good, sometimes it's bad. You know, you check yourself out in the mirror and you're looking there good, buddy, sometimes. Sometimes it's not so kind. The thing is, whatever that thing is that is me or us, distinct from the conversation that runs 24/7 in our head, the conversation that already was, the me part of me believes the conversation whether it's true or not. So if my patient has a conversation running 24/7, essentially saying, "You're not safe, you're not safe," of course she's going to believe she's not safe. I asked my patient if it's simultaneously possible to live in an uncertain, capricious world where the truth is none of us know when our next moment will be, and still, at core, be safe. That bad things happen, might happen, will likely happen, as is the nature of the world, but from an internal safety perspective, you are safe. And to begin the possibility, start the conversation in your head with the words, "I am safe." And it doesn't mean you won't be hit by a car or get cancer, simply that your basic state of being is safe. Speaking safety into existence. As a further example, I said we spoke the concept of America into existence. We called it the Declaration of Independence, right? Appropriate. We hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. There was no evidence for this. They spoke into existence these truths to be self-evident. And so in her case, she could speak into existence, hold a truth to be self-evident that she is safe. So she's going to try it for a few weeks. Now here's an exercise just for the heck of it. What can you speak into existence for a few weeks? I mean, what do you have to lose, right? I'm Dr. Renee Kohansky for the MDedge Psychcast.
And that's a wrap on episode 54 of the MDedge Psychcast. We'll be back next week with another Masterclass lecture. This time, Dr. Donald Black talks about behavioral addictions. The Psychcast is hosted by MDedge Psychiatry Editor-in-Chief, Dr. Lorenzo Norris. Our guest lecturer this week was Dr. Sidney Zisook. The Dr. RK segment is written and recorded by Dr. Renee Kohansky. Our show notes are authored by Dr. Jacqueline Posada. Psychcast audio and content producers were Gina Henderson and Jeff Bauer. MDedge podcasts are produced by Editor-in-Chief Mary Jo Dales, Executive Editors Denise Fulton and Kathy Skarbeck, and Multimedia Editor Terry Rudd. I am your audio engineer, editor, and the host of MDedge Podcasts, Nick Andrews, and you've been listening to the MDedge Psychcast.